Welcome. My name is Nico Lazzarona. Welcome to the first online live international MINEC Night Summit. Thank you, Ashraf Souaya from Tunisia, for inviting me. I'm very honored to be here, to be able to and have the chance to share with all of you my experience in implant dentistry, and in this case, one of the complications that was developed because of not listening to the literature, the scientific literature, that important part of our daily practice that we must be really, really updated. This is why I think that complications in implant dentistry is something that people like to see, and obviously the way that we can either solve the cases or not solve the cases, not solving the cases. But in this case, I would like to share with you not only the complication, but also ask you at the Q&A post-summit of the session, what would have you done in this kind of situation, in this kind of complication? Okay, so let's go for it and let's start the presentation. This is the case of a 26-year-old patient. He's a smoker that actually presents in the clinic with pain in the central incisor, upper central incisor. He received a punch in a fight, and he tells me that he cannot stay like this anymore. It's been 24 hours. He's coming with his girlfriend to the clinic, and I offer him an initial emergency treatment planning for him, which is going to be basically treat the initial problem since we have a pulp exposure with probable contamination of the nerve. So we decided initially to take an x-ray. At that time, I didn't have a CBCT in my clinic, so we only took a periapical x-ray, which normally what it's recommended to do as a normal and standard protocol is when someone receives a punch or receives an important hit in the, especially the anterior area, we should take a CT scan from the beginning in order to see whether we have any fracture or buccal plate loss or, diagnosis, initial diagnosis in 3D, which is the most predictable way to treat these kind of cases. That moment, the only thing that we could do at that time was to do a root canal treatment. So in order to remove all the potential contamination that would start to develop even at the level of the apex, as you can see in the right image, we decided to do the root canal treatment. And as a emergency treatment to offer him a quick initial stage of our treatment and quick emergency solution was to do not only the root canal treatment, but also a provisional acrylic crown and also some aesthetic filling at the tooth that was also affected. Obviously, we tested the rest of the teeth, and the rest of the teeth, the adjacent teeth to the most damaged tooth, the number 12, which is the upper right lateral incisor, the upper left central incisor, and upper left lateral incisor were vital, the three of them. So after 3 weeks, we received a call from the patient. He says that he actually has a lot of pain. We did a root canal treatment on that tooth. So what I am assuming is that I'm going to receive what you see in the right image. I see a horizontal fracture. This is a very, very deep fracture, horizontal fracture. There's no way that we can preserve here. There's no way that even we can do any kind of treatment to preserve that tooth. And at that moment, I do send the patient to a radiology center, and they take a CT scan. And as we were expecting, we see a completely root fracture at the level of the marginal bone that was still preserved, that part of the bone, there's that apical part of the bone that was still there, but the full buccal plate, almost the full buccal plate, was completely lost. And according to the literature, we consider this case a type 2 socket. And what does the literature say when you have these kind of problems in the clinic? Well, initially, this is very important to say it, is that the patient, when he comes, he says, well, if you're going to need to remove that tooth, is there any way that I can get an implant and a crown the same day? Well, I said, all right, just let me think about the case, because we have a patient actually that recruits a lot of negative background, such as he's a very troublemaker person, but he cannot stay with anything in the mouth, like in terms of fixed restoration. He needs either, he doesn't want to have any removable prosthesis at that time. So we were thinking about a Maryland bridge and doing what we should have done at that moment. But in this case, what I offered to the patient was something that was not exactly the appropriate thing for him, even especially because he was even a smoker patient. He was a troublemaker patient, and but at some point I was pushed to give him a solution, a quick solution, in terms of fixed prosthesis and fixed solution without touching the adjacent teeth. So if you look at the literature, as I said before, we consider these a type 2 socket. And there was even from a companion in 2015 from Steve Chu and Dennis Sarno, a subclassification of that type 2 socket. And what the literature says when you have a type 2 socket is that initially you should preserve and regenerate that buccal plate before placing an implant, especially because this is a aesthetic zone. This is the most critical area of the mouth, and especially because this is a young patient as well. And at the end, you will see the highlight, the smile line of the patient, but I'm not going to reveal it now. So the subclassification of Dennis Tarnow and Steve Chu, even they suggest that according to the buccal plate loss, either you have a 5 to 6 millimeter of buccal plate loss in a type 2A, or type 2B when you have it from 7 to 9, or even the type 2C in the third subclassification, you could place the implant the same day of the extraction according to their protocol, regenerating that buccal plate. But that buccal plate will be able to be regenerated depending on the jumping distance, especially in very, very thick alveolar ridges. And this is very important because if you look at the literature a little bit earlier than the subclassification from Dennis Tarnow and Steve Chu, you see that Daniel Booz in 2009, he considers that in any case, there's no way that you, in a type 2 classification, you can do an immediate extraction, immediate implant placement. You should wait for either the early or the late. And considering the early from 4 to 8 weeks, if you want to find an unmature bone, but you still are going to be able to place your implant, or even from 12 to 16 weeks, that you're going to see you're going to check a more mature bone. And in any case, after 6 months, you're going to see a very, very mature bone, especially if you have performed a socket preservation technique. And yes, I should have done this. I should have done the extraction following the scientific literature and following the guidelines in order to preserve that bone, and following also the biology that supports this concept. I should have done socket preservation. And, if you want to do, obviously, a flapless technique, which is the recommended thing to do in these kind of cases, a soft tissue punch to warranty the presence of soft tissue and not mucogingival junction displacement to the palatal area. And after 6 months, I could have done an implant placement with immediate loading, but this is not what I did. I didn't do this. I wanted to break the rules, and I wanted to do an immediate extraction, immediate implant placement, and immediate loading at that moment. So I did what I should have not done. And this is the way, and this is I think that the way that we learn from our mistakes and we learn from our bad and wrong decisions. So what I did was a subcrestal intersuccular incision. I used a automatic forceps from Dowell with a specific tip that allowed me to remove the remnant tooth very easy. In this case, obviously, this was a fracture fragment that actually had the residual apex still present on the most apical part of the socket. I use these diamond-coated elevators that actually allow me to dislodge very easy the remnant roots, and I strongly recommend to use them. And this is the confirmation of the absence of remnant tooth inside the socket. So important at this moment is that when I look at these pictures, one thing that I assume is that I need to curate the area, because especially when we have a situation where we had a tooth that was creating some granulation or reactive tissue, usually what I'm going to find is a lot of granulation tissue attached not only to the tooth, but also to the hosting bone. This is why I consider and assuming that I'm having a buccal wall lost, but a papilla preservation, a papilla preserved. Obviously, I'm having interproximal height of bone, so the papillas are not going to be the problem, but I have a huge dehiscence on the buccal plate. So at this point, I decide to elevate a flap. And why do I decide to elevate a flap compared to the Dennis Turner and Steve Chu publication in the Compendium 2015? Because I consider that in these kind of situations, I have a lot of granulation tissue that is attached and inserted into my hosting bone. Because when I first shared this case with some colleagues, they actually, one of my colleagues here, he sent me a case and he actually criticized my open flap technique. And I understand that in situations, especially in 2020, we should be very flapless, we should be very minimally invasive, and opening flaps are going to have a negative response by the tissues, especially when we're removing and detaching the periosteum from the facial bone. But in these kind of situations, he wanted to share a case with me, and I want to share with you the case that he shared with me. He said, you know what, I don't elevate the flap in situations like that, even though I have a big dehiscence. This is a case that he shared with me in the central upper left central incisor. He did the extraction, and he placed a collagen membrane on the buccal aspect. He tried to detach as much as possible the periosteum. I don't know how someone is going to detach periosteum by using a microblade to do a split thickness, because at this point you need to go full thickness and remove as much as possible all the attachment that is connected to the facial bone and the facial plate. So at this point, he showed how he placed the membrane inside the socket, everything flapless with a lot of bone, even overbuilding the area. And after, I think he says 4 months, he places a Maryland bridge, and after 6 months, he says 100% maintenance. Yes, he shows 100% maintenance, but a horizontal volume that is not perfect, is obviously completely lost. He has a great result by rebuilding the original aspect in terms of visual original aspect by doing a connective tissue graft to bring back the original architecture of the soft tissues. But as my mentor says, and I will always remember, the tissue is the issue, but the bone sets the tone. So you need bone actually facially from your implant. This is what's going to stay there as much as possible. And you don't have to be afraid of vertical incisions in the aesthetic zone when the case requires it. And for me, this case required to open a flap. Well, I didn't do a big flap. I considered that here I did, I preserved the papilla from the central and the lateral from the contralateral aspect. I elevated the mid facial papilla. I elevated, obviously, the papilla from the adjacent lateral, but I preserved the papilla from the lateral to the canine. Well, at this point, I have a lot of bone interproximally, so that is not going to be a problem. The problem is that whenever I see these huge dehiscences, I'm going to see a lot of reactive tissue that is attached to the bone. And if I am not able to remove and scratch and completely eliminate all the insertions of the periosteum or reaction of the reactive tissue or the granulation tissue to the bone, even if I'm packing a lot of bone there, I'm going to have encapsulation of my particles, and probably those encapsulations are going to end up removing and speeding out all those particles, developing a huge buccal lingual collapse. So at this point, what I wanted to do is I wanted to expose all the irregular margins of my dehiscence and obviously evaluate my defect. This would be impossible by not elevating a flap to reach all those irregular margins that still, even in that picture, even though I'm elevating and curating everything, I still have some more remnant of reactive tissue, granulation tissue that is still adhered to the hosting bone. So one of the things that I obviously share with my friends is that obviously I'm not going to have any papilla collapse because I still have a good interproximal bone there. But I do evaluate according to the compendium from Steve Chu and Dennis Tarnow, that they say that the type 2A and 2B, they can have very good results by preserving the flap and regenerating the buccal gap with bone graft at the time of the implant placement. But in the type 2C, which is the one that you actually have about around 10 millimeters of bone loss, which is this case, they should consider, or they consider that you should do a socket preservation and delayed implant placement because the stability of the tissues are not warranted. So in this case, I wasn't the type 2C subclassification, but I wanted to place my implant. So what I did is I considered that as long as I have, and that's what they mentioned as well in the article, they mentioned that as long as you have a lot of jumping distance, you're going to be able to regenerate, because more jumping distance you're going to have, the more regeneration and the more potential regenerative potential in terms of regeneration you're going to have. So I follow my drilling protocol, and I place my 5x13 megagen implant NRH into the site. Obviously, these are amazing implants that actually have a beautiful insertion, a beautiful primary stability, and I even place my implant in the proper 3D position. I tested, I have a good ISQ values, more than 70, and I'm very happy at this point. So I place a healing abutment that is going to support everything that I'm going to do. Is supporting the palatal tissue at this point, and it's going to support my buccal bone that I'm going to place. I use a pericardial membrane, and this is the jumping distance that I was mentioning before. I have about 5 millimeters, 6 millimeters of still alveolar ridge that I need to fill in order to reach the buccal, the bone envelope. The frame, I'm still inside the frame, so I still have a lot of bone potential there. I'm inside the socket. So I consider that in this kind of situation, it's going to be quite predictable to regenerate that facial bone that is lost. And I place, as I said before, my healing abutment. I use my pericardial membrane. I usually use pericardial membrane because these membranes have a very slow rate of resorption, and I use a connective tissue graft because I consider that I need to rebuild and give an extra layer tissue protection to my facial aspect in order to be able to compensate any kind of collapse. So I do my connective tissue graft, and at this point I need to be very, very predictable. I suture my connective tissue graft with Sterling suture 6 zeros, and at this point I'm going to place my bone graft. This is a xenograft, and I'm going to fix my membrane by using a periosteal suture. So the way that I'm going to use it, and the way that I'm going to avoid any micro movement of my membrane, is by suturing my resolvable sutures. These are PGA, polyglycolic, PGA sutures. 40. I'm going to come from the palate. I'm going to go over the membrane. I'm going to reach the attached periosteum, not the one that I've released, the one that is attached. I'm going to go over the connective tissue graft that is attached, that is sutured to the buccal flap. And I'm going to come under my connective tissue, over the membrane. I'm going to come back, and I'm going to suture in the palatal aspect. This is the way that I suture the membrane. This is the way that I secure the membrane in order to avoid any kind of micro movement, because what I wanted to do is I wanted to host my bone graft into position and avoid any micro movement that is going to promote the encapsulation of my particles. So I have some apical anchorage of my suture. I have my connective tissue graft in place, and I was able, even with the nice and beautiful ISQ values, to put my crown, immediate provisional crown over my post-extraction implant placement. And at these points, I did some vertical sling to coronal advance my flap, even move my zenith point 2 millimeters over the CEJ from the adjacents, and I was able to try at least to compensate the shrinkage of my flap. And according to what I saw before and comparing what I saw before when I had my open flap, I think that this was kind of very minimally invasive at this point. So I take some x-rays just to confirm that there is a good connection with my implant, there is a lot of bone. And after 2 months, after seeing the patient basically weekly, so every week I used to see the patient, this is what I see. Suddenly from 1 week to the other, after 2 months, I see that buccal gap. So I see that I still have the zenith point of my gingival margin quite more coronal compared to the adjacent one, but this is what I see. So what I considered at that point is I wanted to trim perfectly and I wanted to work in the mouth. It was a closed environment, so I didn't think that I was going to contaminate the area, but I put some composite, flowable composite at that moment in order to remove the crown and then polish it and trim it perfectly in order to put the crown back and support the tissues. And this is what I see. This is the way that it looks at this point. Some support, some, you know, everything was fine at this moment. The patient didn't have any pain and we were happy until this happens. After 1 month, I see huge collapse. There is a huge dehiscence that is affecting not only the attached gingiva, that it's reaching even the frenum. So there is even some growth of the frenum and some muscle fibers and the frenum fibers that are even combining and sharing some space of the gingival space with my previous attached gingiva or keratinized gingiva at that moment. So I see a migration of my mucosa and my non-attached gingiva to the most critical aspect of my crown. So this is what I see, and I cannot believe this happened. Obviously, you can see how the patient was a smoker and how he was not treating very well. And I wasn't afraid of my interproximal bone because I was afraid, about my papillas because I had interproximal bone. What I was afraid is that this was keep growing and growing, and I had a huge soft tissue dehiscence. At this point, I'm not afraid of the implant. The implant is fine, but I need to do some aesthetic and mucogingivoplasty, mucogingival surgery to the patient. So I decided to do a connective tissue graft to increase the soft tissue collapse and also a double papilla flap for what I would consider a root coverage, right? So this is what I do. I do two verticals that start at the paramarginal level of my papillas. I do a split thickness and I expose all that connective tissue that is under my flap. I grab the 2 mini flaps. I depithelialize the area in order to approximate and put those 2 mini flaps together. I use acetylene sutures to connect the both depithelialized areas to basically, after that, putting my connective tissue graft under my flap. And once that double papilla flap was performed, I reposition my double papilla flap to the hosting connective tissue. I suture my vertical incisions. I use some apical nylon very long in order not to pinch the patient. This is very important. And I place my provisional crown. So this is 1 week later. I was afraid of results. I was afraid of this patient not being compliant. This is what he wasn't from the beginning. He wasn't a compliant patient. But after 3 months, this is what I see. But at least I still have, and I brought back some keratinized gingiva to the area and to the most critical aspect. I see some keloid. This is the biscuit triane. I see keloids, and I see a reacting tissue, but at least I'm not seeing any redness under my flap that it's addressed to problems, underlying problems, inflammatory cells, etc., that I don't see. At least I see some gingival tissue that it's stable at that point. I do some follow-ups because I consider that I had some bone graft particle loss. Obviously, I had a lot of particle loss. in despite of not doing anything flapless, I basically exposed the bone that was damaged, and I cleaned everything. But I did everything as I thought that everything was going to be all right, and it didn't work well. Well, obviously, I didn't follow very well the most scientific literature. This is the final crown delivery. At this point, I don't want to touch the patient, because if I was going to blend this kind of surgery, I wanted the tissues to stabilize a little bit more. This was basically 3 months after doing that mucogingival surgery and that soft tissue surgery. So I wanted the soft tissues, before I blend this with either laser or with a high-speed burr, I want this soft tissues to stabilize, because at this point I don't believe in anything. But if you compare the before and after, well, at least we were able to bring the soft tissue stiffness and secure that critical area in the most aesthetic aspect. So we learn from our mistakes, as I said before, and even though this patient was a low smile line, I consider that there were many things that were not well properly done. This is why sometimes we experience complications, because you can experience complications because you have bad luck, because of many factors, because complications and failures are multifactorial. But in this case, we actually looked for that complication. The first thing is that obviously it's not because I want to get rid of my responsibilities, but the non-cooperation affected the outcomes. These patients never quit smoking, even though we strongly recommended it. We actually forced him to quit smoking. The one-stage approach at this point, without following the most scientific literature, was a risk, even though we had jumping distances according to the papers from Dennis Starr and Steve Chu. Obviously, asking the body to do so many things, stabilize the membrane, interfere with the immediate loading, and interpositioning a connection with some regeneration that actually needs to take over, obviously was a risk. And the moment that we had some initial collapse, we didn't support properly the soft tissues. So one of the things that I learned as well is that when we are working with provisional, especially when we are trying to drive the tissues, we need to first have in contact with the tissues to support the tissues. If we don't support the tissues, we're going to lose the tissues. So at that point, the moment that actually the patient came initially with a little bit of recession, the little gap, I should have supported the tissue, and I didn't support the tissue. I still left the gap if you look at the presentation before again. And obviously, the soft tissue management is really, really important in order to solve these kind of problems, especially in the aesthetic zone. What would I have done today? I would have done in 2 or 3 stage approach. I would have done the extraction and socket preservation with GBR. So, or the GBR if you want to open the flap, but you need to do it stagely. Sometimes you need to stage your approach in order to be predictable. And then I would have done the implant placement with connective tissue graft with the immediate loading. So, this was my case. I hope that you enjoyed this complication. I hope that you took some important tips and pearls from this. And always, my take-home message, as I said before, I think that we should follow the scientific literature always, because the literature and the researchers are doing a great job, especially when we have a very consistent literature, the one that is supporting our ideas and our concepts. So I strongly believe on the really real and truly scientific literature before making decisions, especially in the aesthetic zone, but actually it's a critical zone, it's a critical area. So thank you very much. Thank you, Ashraf Suwaja, for your invitation. I hope that this actually makes a lot of debate, and we can actually share some thoughts about this approach and share some experience together after this presentation. So thank you very much. Thank you, all of you, for sharing, and looking forward to see you all. Bye-bye in case discussion. Bye-bye. Thank you.